We are live
So,
now.
yeah.
Good evening,
So,
esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Bridging Gaps in Maternal and Child Safety in a Vulnerable World. It's my privilege to introduce the convener of today's webinar, Dr. K.S. Jairani Kamraj ma'am. Ma'am is the Senior Consultant of Reproductive Medicine and also Director, Akash Fertility Center and Hospital, Chennai. Ma'am has been the Vice President of Tapisar, South Zone Coordinator of No to Wow Committee, President of OXY in 2023, Joint Secretary of TNFOG, Associate Secretary of World Association for Sexual Health, Advisory Council Member, World Association for Sexual Health. I welcome you, ma'am, and I hand over the session to you.
thank you, Sahiti. Good evening, senior faculties, dear senior Foxians, and my dear friends, and my respective chief guest of this webinar, Dr. Rohit sir, the guest of honors, Dr. Parul sir, Dr. Archana madam, Dr. Geetendra sir, and the mentor and the guide of this webinar, Dr. M.C. Patel sir, all the senior faculties from Gujarat, presidents, secretaries of various societies who have joined here for this webinar on the bridging the gaps in maternal and the child's safety in this vulnerable world. So we all know we are into a world which is marked by increasing disparities, conflicts, and a lot of fragility in the maternal and the child health, which remains one of the most urgent needs in the globally. So vulnerability towards today takes a very major form, and it is our importance that we as a clinician should work on this safety of the child, which is very important, and also the safety of the maternal mother. So here we are here where we are going to bring together the safety about the child as well as the safety about the mother in this webinar, where we are bridging the gaps from the child safety to the maternal safety. And we have here in this webinar all the senior faculties from Gujarat who have joined hands to carry this important theme into the knowledge of all the participants who are joining here as delegates to take home the important message on the child safety as well as the maternal safety. So we have here almost 8 societies from Gujarat, and almost national-wide we have all the delegates who have joined here to listen to this webinar. And I'm very honored and humbled to have here the senior Foxian, the Foxy president, past president, Dr. Bhatt sir, who has happily consented to be the chief guest. I welcome you, sir. And we start this webinar with all the blessings from God. And we always start with a blessing from Tamil Thai, which we feel that it is a very important moment to get the wishes and blessings from Tamil goddess. So now we are moving on to the very cultural aspects of the Tamil, the lightning, the Kuttuvilakku. Just as light dispels the darkness, awareness and action dissolves the shadow of vulnerability surrounding the mothers and the children. So we start with the lightning of Kuttuvilakku to dispel the darkness and create an awareness for the child and the mother's safety. So I have the great pleasure, honor, and a great respect. I'm humble to welcome the chief guest for this webinar, Sir Dr. Rohit V. Bhatt, sir. Sir is the past president, dynamic president of Foxy, who is the chief of the Department of OBGYN in Admin General Hospital, Ahmedabad. And he is a Lifetime Achievement Award from Foxy, Narshi, and also from Harvard University. And Sir is the past vice president of AOFOC, and he is the very proud recipient of BC Roy Award and an eminent teacher, a best teacher, mentor for many of the senior Foxians. And he is the former consultant of the WHO to WHO, Population Council, Family Health International, and also John Hopkins University and PCI. Sir, we are honored to have you, sir. May we have your blessings with the word of wisdom, sir.
Thank you, Kiran. Am I audible?
Yes, sir. Yes, sir.
I must congratulate Kiran Kamaraj and your team for selecting such an important subject, which I feel was neglected all this time. The social aspect of our profession is not taught during undergraduate as well as during postgraduate courses. And this is now the right time that our members, Foxy members, and other practitioners are made aware about the social responsibility we have about mother and the child. These are very important topics, and I note we got very expert speakers on this, and I'm sure this CME will be an excellent one, supporting, educative, and informative. I wish your program grand success. Thank you very much for inviting me.
Thank you, sir. Thank you so much for your blessing, sir. You are a real inspiration for all of us, and it is a real blessing for us to have you here, sir. Thank you so much, sir.
Thank you.
So, may I have the CV of Sir Parul, sir? It gives me great pleasure, honor, and I'm really blessed to have here Dr. Parul, sir, who is the past chairman of the ICOG and the vice president of ISOBAR and the professor and the head of the department of SAL Institute of Medical Sciences, Ahmedabad. And he's the senior consultant of the Cotterell Women's Clinic. And he's the chairman of the education committee of SAFOG and the Indian coordinator to NESA, IAS. And also he's the past vice president of Foxy in 2006 and the president of the state organization of OBGYN of Gujarat 2009 and the chairperson of the scientific committee of ASCOG 2017. Sir, we welcome you, sir, and it's very blessing to have you, sir. Can we have your word of wisdom and blessing for this webinar, sir? So you have to unmute. So you're muted, sir.
I was trying to unmute myself and it took some time. Well, Dr. Jayarani, thank you so much for asking me to be part of this webinar. And it is a pleasure to see Dr. Rohit Bhatt here. I'm seeing him after quite some time. And it is so good to see him in good health and so fresh. Well, I do see that you have chosen a very important topic of bridging gaps in maternal and child safety and vulnerability. And all three sessions would be very vital for our colleagues. The obstetric collapse handled by Dr. Aruna Suman. Then I see some of the panelists whom I know, but many I do not know. Akash, Dr. Jignesh, these three I know personally, but all others will definitely be adding to the deliberations. I see that another topic is POXO, and you have an expert with you in MC Patel, and then Doppler to be handled by Ruta. So I'm sure all these three topics are going to help all the participants a lot in their practice as well as handling the practice. And I also wish you all, those who are contesting for election, best in their Foxy endeavors. Thank you for asking me to be here.
Thank you, sir. Thank you for your kind words, sir. So we have the pleasure and honor to have here Dr. Archana Dwivedi, madam. Can I have Madam CV?
Yes, ma'am. 1 second, ma'am. Yeah.
Yeah. So Madam is the chairperson of the Midlife Committee Foxy 24-26, and she is the national chairperson of the IMS website 23-25, and she is the president of Baroda OBGYN Society.
We'll end it
21.
here only. Thank you
Madam?
for the invite. Actually, we'll just cut it short because I think we are standing in.
No, ma'am, it is our formal. You are the guest of honor. We must introduce you, ma'am. Introduce you. Definitely, it is our honor to have a few words of yours, ma'am. Madam is practicing over 20 years in Vadodara, and her key interest is high-risk pregnancy, laparoscopy, and vaginal surgeries. And she has very important accolades, very many accolades. A few among being the first prize at West Zone UA Foxy Superstar Foxy Award 2020. And also the West Zone, she's the coordinator for the West Zone for the breast adolescent chief lead with the West Zone Breast Committee. And she has so many publications in IMS Journal, 4 chapters in Foxy Focus. And in 2018, she has written chapters, and also she has written chapters in Foxy 2023 chapter in the book, Foxy book. So Madam has been a faculty in various national and international conferences, and she is the West Zone coordinator for the Breast Committee and the Adolescent Committee. Over to you, Madam, for your kind words.
Thank you, Dr. Jayarani. It's a pleasure, and it's rather, I'm very honored to share the screen with so eminent my own teachers, Dr. Rohit Bhatt and Parul sir. Happy Guru Purnima, sir, to you and Parul sir and other faculties over here. I'm just on the eve of this thing, and really thank you, Jayarani, for giving me the honor to be with everybody. As Parul sir already said, and seeing Aruna ma'am after a long time gives a smile on my face automatically. And seeing other eminent faculties from Gujarat, and very justified. I mean, I'm the title you have chosen, the vulnerability, that is itself explanatory. And I'm looking forward to have a great session and with Dr. MC Patel sir over here. Sir, happy Guru Purnima to you too. And I'm looking forward to the session. As Parul sir had already said, that is going to be a beneficiary for all of us. So I'm also staying back to learn, and best wishes, Jayarani, to you, Dr. Aruna ma'am, and all the contestants. And I think with Bhatt sir and Parul sir in the picture, the blessings are very, very important and very pious, I would say, for today. So carry on with the webinar, and it's an honor again. Thank you for having me with you at this platform. I'm eager to listen about the POSCO Act by reputed Dr. MC Patel sir and my guide as well. So I'll be waiting to hear from him. And also Ruta is there, a good friend, and the panel itself is a very, very wanted thing. I want to give a ear and learn much from that. Thank you for making me a part. Thank you so much.
Thank you, Archana ma'am, for joining us and giving your inspiration. Thank you so much. I think Dr. Geetendra sir is on the way. He'll be joining. But we will introduce him. Sir, once he joins, he'll say his message. So, sir is the Vice President, Foxy 2022, and he is the Chairman of the Ethic and Medical Legal Committee 2017 and 19. And he has been the President of the Ahmedabad OBGYN Society between 2016 and 17. And he has been the Joint Secretary of SOGOG 2018 and 19. And he is the President of the BVP Shahibag between 2008 and 11, and he is the medical legal consultant for many medical legal consultancies, and he has authored very many books in the OBGYN regarding the OBGYN laws and law what a doctor must know. So we welcome you, sir. And once sir joins, I think he's on the way, he's driving the car. He said that he'll join. So thank you so much. I thank our chief guest, Sir Rohit Bhatt sir, our guest of honor, Dr. Parul sir, Dr. Archana ma'am, and our mentor, Dr. MC sir, for joining us in this inauguration. And thank you so much for being with us to guide us and to inspire us. Thank you so much. So we'll move on to the academic sessions. We'll have the first session. The chairperson for the first session is Dr. Sheetal Talekar. She is the president of the Vapi OBGYN Society. We welcome you, madam. And we have Dr. Kokila Desai. Madam is the practicing and the chief fertility specialist in Shivam International IVF Center. And she has done her graduation and post-graduation from Odora. And she has got the training from the endocrinology, reproductive endocrinology from Germany. And she has presented very many papers in different conferences, national and international. And she's the fellow of the reproductive endocrinology from Germany. and she's the past secretary of the Gujarat chapter IFS 2022-24, and she's a life member of IMA and various organizations. We welcome you, madam. Over to the chairpersons for introducing the speakers.
Hello, ma'am. Dr. Ruta here. Hello.
Hi, Dr. Ruta.
Just Kokila ma'am has just messaged me that she is busy in some emergency, so she cannot join at present. So she has sent apologies for the same.
Okay. So Sheetal is there?
I'll do
So
the
then-
honors if so. Let me.
Aruna, can you introduce sir? MC sir, Aruna, can you introduce MC sir?
Yes, Dr. Jairani, thank you for this opportunity. And it's my privilege and real honor to introduce Dr. MC Patel, sir. He's a consultant obstetrician gynecologist at Medico Legal Counselor, Nehru Maternity and Nursing Home, Ahmedabad. Consultant obstetrician gynecologist and Vice President Foxy 2018, Organizing Secretary of AICOG 2017, Chairperson of Ethics and Medical Legal Committee Foxy 2011 to 13, Honorary Secretary, State Organization of Gynecologists and Obstetrician of Gujarat 22 to 24, Organizing Chairperson MM Conference in 2018, Honorary Member, National Inspection and Monitoring Committee, PNDT Act Government of India 2015, Honorary Member, State Supervisory Board, PNDT Committee, Gujarat State, President Ahmedabad OBGY Society, Honorary Member, National Managing Body, Indian Red Cross Society Headquarters 2019 to 22, National President, National Medicos Organization 16 to 18, President IMA Ahmedabad Branch 2007 to 8, Honorary Surgeon, Indian Red Cross Eye Bank, collected more than 1,000 eye pairs. Organizing Chairperson, Vivekanand NMO Conference in 2013, President Lions Club at Gatlodia, Ahmedabad, 97 to 98. I welcome you, sir, and it's our privilege to have you here today.
Thank you, Aruna, for kind words.
Thank you, sir. And again, I feel wonderful and feel very, very happy to introduce Dr. K.S. Jairani Kamraj, who is very down to earth, very hardworking, dynamic, and she needs to be in Foxy definitely. And she is Senior Consultant of Reproductive Medicine, Infertility and Sexual Medicine, Director, Akash Fertility Center and Hospital, Vadapallani, Chennai. Awards, Best Doctor Award by MGR Medical University, Chennai. Rajamani Janaki Raman, University First Prize in OB-GYN. And Dr. Vadamalayan, Endowment and Gold Medalist.
Aruna, we'll move on to the session, Aruna.
Please let me introduce Gold Medalist in MBBS, Gynos Positions, South Zone Coordinator, No to War Committee, Vice President Tapasar, and President Oxy 23, Joint Secretary TNFOG, Associate Secretary World Association of Sexual Health, Advisory Council Member World Association of Sexual Health. I welcome you with a very warm heart, Dr. Jairani.
Thank you, Aruna. Thank you. Can I share my slide?
Please.
Can you see my slides?
Yes, but you need to put it in a slideshow.
Is it okay now?
No. Please put it in a slideshow, Jairani.
Yeah, I will do that. Is it okay now?
Yes.
Okay. So thank you, Aruna. Thank you for your kind introduction. And I'm very happy and blessed and honored to have with me, sir, the master of medico-legal, anything in the legality, it is sir. He is a man of encyclopedia regarding any of the medico-legal issues. And we are very honored to have him here. Sir, I welcome you, sir. And it is very my honor and pleasure to have a dialogue with sir regarding the POXO Act and the adolescent care. So we know pretty well why this is needed. What is the need for this dialogue for an gynecologist or an obstetrician will be a big question for many of the practitioners. But we should know this act because, as you see, there is an increased incidence of the child sexual abuse. If you look into the NCRB, that's the National Crime Bureau's record, 2022, over 55,000 cases were registered under POXO, and 47% of rape victims in India are minors. Very sad situation. And in Tamil Nadu, where we are really look at as a culture as a very important one, we can say around 3,000 cases are reported annually under POXO. And 2018 Ministry of the Women and Child Development study found that 53% of the Indian children are reported experiencing some form of sexual abuse. Boys and girls are vulnerable, but boys report less due to stigma more than the girls. And abuse, very, very sadly, it occurs within the homes and in the known circles. 94% of the offenders are known to the child, to the family members, teachers, or it could be neighbors, or it could be an acquaintances, or it can be a very close relative. So this creates a lot of culture of silence among the families, and families often discourage reporting this in the honor of thinking of protecting the honor or due to emotional dependence, as the perpetrator is usually a family member. So, and all the more when you look into the judiciary system, the conviction rate in the POXO is only 32%. And definitely there is a lot of pending cases in the court. Thousands of cases are pending in POXO, and courts also lack of infrastructure, mainly due to the untrained judges and difficulty in getting good infrastructure. So this carries a burden to the healthcare providers like us, because we know pretty well whenever a child abuse or whenever a rape comes, it is the first they come to the gynecologist. So as a women doctor or a gynecologist, we are into the position of seeing any rape victims. It could be a child abuse or it could be a victim. We are the one, along with the pediatricians, have the greatest trouble of how we are going to look into these children, or how we are going to treat them, or how we are going to take these cases. So it becomes a real challenge for us, especially for the gynecologist. But we know pretty well the POXO Act is very powerful. So we, as a gynecologist, should know how we have to look into the patient, how we have to take the history, and what are the details of the forensic examination of these children, and how to document and take the proper way of a lot of legal aspects. So this makes us into a real hesitancy, because many times the gynecologists, they never take this as an MLC registration. In a government setup, in a government hospital, it is very comfortable. But when you look into the private sectors, it is really challenging, that we don't know how to approach such patients, where to inform, how to do all these things. That becomes a very, very important challenge. So to unveil this challenge, we are here to look into the POXO Act, how it is related to the practice of the gynecologist. And we have here sir, who will be enlightening us regarding the POXO Act. What is its implications? How we have to do about what are the impacts on this on the routine practice? How we have to approach a victim? How we have to report? How we have to document? All these things has to be properly streamlined, because the POXO is very strong and we should know about it. Sir, may I know how what is the POXO Act and how it is related to the practice of the gynecologist? Over to you, sir.
Yes. POXO Act means Protection of Children from Sexual Offences. And it was enacted in 2012, and some amendment came in 2019. So as far as this POXO Act is concerned, it addresses all minors. Minors under this POXO Act defines any person less than 18 is minor, and it is gender equal. So it addresses both male and female. So as far as this POXO Act is concerned, it is this. And it is for special consideration for these cases related to minors and for special juvenile court, special police station. But in all the places, if there is no special police station, then in common police station also one can report, and it is to be taken seriously. It is to be taken in a fast manner, and this type of cases are dealt with in court very fast as compared to other cases.
Yes, sir. So as you rightly said that this POXO Act came in 2012 and there is an amendment after that. And there are a lot of issues that we have to know about it. Sir, when a minor child comes to us with the signs of sexual abuse, what we should do, sir? How to proceed, sir?
Very important part is whenever this type of patient, whether a male, female, having a history of sexual offense or assault rather, they are to be taken care immediately, because under this POXO Act, all these victims have right to be examined, to be treated, to be taken care of immediately. And merely on ground that it is a MLC case, you have no police requisition letter or no magistrate order, you cannot deny on that ground. Even if you cannot deny that it is private hospital, this type of cases can only be dealt with in government hospital. It is not like that. So whether it is government, whether it is private, once this type of cases are brought to us, we have to deal with these cases, to examine them, to treat them, to collect evidences, to form opinion, and to report police. And whenever called or asked to be present in court, then to be an expert witness in court also.
So one important question, sir. So when
Yes.
this child comes, we have to examine the child because it's in sexual abuse. We have to get a consent. To
Yes.
whom we can get the consent from, sir? Or is the consent is important? If so, from the child or the parent? And
Yes.
even if they refuses, what we have to do?
If a child is more than 12 years, though she is minor, but in eye of law, she is considered as a mature minor, so she can give consent for examination. But at the same time, if any surgical intervention is required, or some sedation or anesthesia is required for examination or for further treatment, then in this situation, consent from guardian will be required. So she can give consent only for examination if she is more than 12, but she cannot give consent for any surgical intervention.
Thank you, sir. Thank you. So, so if at all, if we are planning for an MTP, or if she comes with a pregnancy at the age of 17 or 18, how we are going to take care of her MTP as well as her delivery? What is the norms that we have to follow? What are the rules, sir?
So as far as termination of pregnancy is concerned, we will have to look for two acts, POXO Act as well as MTP Act. So under POXO Act, all these children are also allowed to get terminated if her physical health permits us to go for termination of pregnancy. And as far as this MTP Act is concerned, up to 20 weeks of pregnancy, when she is victim of POXO, because under POXO, when she is less than 18, all the cases are considered as a case of rape. And when she is rape victim, then it becomes an indication for termination of pregnancy up to 20 weeks of pregnancy with opinion of only one registered medical practitioner. If she has pregnancy having more than 20 weeks and less than 24 weeks, again being a minor, again being a rape victim, again being a sexual offense victim, it becomes indication for termination of pregnancy, and pregnancy can be terminated with opinion of two registered medical practitioners. If pregnancy is less than 20 weeks, we have to go with two forms, Form C, that is form of consent, and that will be signed by guardian, because she cannot sign consent form for termination of pregnancy. And if pregnant, this is prescribed Form 1, that is form of opinion. So registered medical practitioner will form opinion in form 1 to terminate pregnancy. During 20 weeks and less than 24 weeks, 2 registered medical practitioner opinion, and there is prescribed form, that is form E. So in form E, 2 registered medical practitioner will opine and pregnancy can be terminated. If pregnancy is more than 24 weeks, even if she is case of POXO, even if she is case of sexual assault or case of rape, if pregnancy is very normal, then medical board has no power to opine. But if fetus is having a congenital anomaly which are incompatible with life of fetus, then medical board will opine that pregnancy should be terminated, and with opinion of medical board, one can terminate pregnancy, and medical board will opine in prescribed form D. It is one more form. But if pregnancy is normal, even if she is rape victim, even if she is minor, she cannot be given, I mean, medical board cannot give opinion for termination of pregnancy. So in this situation, one will have to rush to Honorable High Court seeking writ petition for seeking termination of pregnancy. So these are some impacts as far as abortion part is concerned or MTP part is concerned.
So should we preserve the DNA, sir, if it
Yes.
in a post
Yes,
POXO?
yes. So we can terminate pregnancy, and at the same time we will have to inform police, and we will have to hand it over product of conception which is to be preserved in normal saline, and we will hand it over to the police. Many a time it may happen that police may not turn up to collect this product of conception. So once we inform, our job is over, but we know it is to be preserved in normal saline, and after 72 hours, that product is not that much available for DNA testing also. So we will again inform police that it is always better to collect before 72 hours, and it is to be handed over for further investigation if at all we want to go for DNA testing, etc. In this type of situation. In spite of all this, if police doesn't turn up, then your job is over. Once you inform, your job is over. But again, you will have to inform with acknowledgement, because many a time it may happen that police or a person whom you inform may go hostile. They will say you never inform, you didn't inform. So you will have to prove in court of law that you had informed. So whenever you inform police, you will inform with acknowledgement. So say for example, if you send your staff with 2 letters, then 1 letter is to be signed by that police station officer, and every police station officer are given Bakkal number. So we have to ask for Bakkal number, name, time, and date we have to mention in that very letter. If police station officer refuses to give acknowledgement, then in this situation you can have a phone call to number 100. It is recorded call. But in this situation, you will identify the person whom you are giving information, name, Bakkal number, time, and date, just I mentioned prior. So it is recorded call, and you can prove in court of law that you had informed. You can send all this information by registered ID post also. You can send it by mail. You can send it information from your mobile also if you have facility of recording in your mobile. But in all this situation, you will identify person whom you are informing about the case. So these are some provisions as far as POXO Act is concerned, to whom to inform, how to inform.
Thank you, sir. Thank you for that elaborate way of explaining things, sir. But if a gynec feels so much of formality is there, should I report? All these things becomes a very stress for her. So if she fails to inform or report to the police, what is the what happens, sir? If can they is they what are the legal risks the gynecologists face if they do not report this to the police?
Under section 19 of POXO Act, any responsible citizen of India is under obligation to inform police or CWC, that is Child Welfare Committee, once he come to know that she is minor and she is victim of sexual offense. One has to inform under section 19. And if one fails to inform, fail to report, under section 21, there is a provision of 6 months of imprisonment. And if he is a head of the institution, then there is a provision of 1 year of imprisonment. And for repeated violations, there is a provision of 1 year with fine or both. So these are the provisions, and we cannot afford that. And that is why we have to inform police in this type of situation when she is minor and when she is victim of sexual offense.
So it's fine, sir, that for the MTP we are collecting the DNA. But if there is a abuse or if there is a rape and they come with a rape victim, so are we justified in collecting the evidence? If so, how? What is our role in this forensic evidence collection, sir?
So just I mentioned that we are under obligation to inform police or CWC in case of any minor of sexual offense. And again, whenever we are called in court of law, we will have to prove it, that how we came to diagnosis that she is victim of this sexual offense. And for that, we have to start with consent. Just we discuss about consent and certain history of changing clothes after this incident, history of bath after this incident, history of menstruation at the time of incidents, at the time of examination. These are certain relevant things we have to inquire about, because we have to ultimately come to the conclusion. We have to examine all the injury marks, if at all it is there, over breast, perineum, genitals, any other part of body. We have to mark all these injury marks. We have to collect some evidences, say for example, undergarments, stain of blood, stain of semen, or stain of any lubricant or so. So we have to collect all those for evidence as far as our clothes are concerned. Any mark on body, say for example, blood stain or semen, we have to scrap that, and it is to be collected in a sterile bottle, and we have to hand it over to the police. All these evidences we have to go. At the same time, we are also under obligation to treat that very patient. If she is bleeding profusely, we have to naturally treat accordingly. If there is some foreign body inside, we have to remove it. And many a time we have to suspect that accused could be HIV positive or so, sexually transmitted disease. So we have to offer prophylaxis of STD also as far as this type of cases are concerned. So after treatment, after collecting all this, we have to form opinion whether she is victim of sexual offense, and we have to report to the police station or CWC. And whenever we are called in court of law, we have to appear in the court as an expert witness and to give our opinion about this offense.
So regarding next, we have to, when the child is emotionally disturbed, how we have to approach her. That's very important, what we have to do as a gynae. So should we call the pediatrician, or can we approach the child in how to approach, what is the way that we should approach them, sir?
So if it is an emergency, then naturally we have to deal with first. Say for example, she is profusely bleeding or some injuries. So we have to deal with. But in this situation, we may ask help from pediatrician also, just to mention. We can have help from psychiatrist also, or clinical psychologist also. If any family member with whom that child is comfortable, we can keep that person in examination room for that child. But many a time it is also observed that person who brings the child could be accused or could be culprit. So in this situation, first we have to ask that very child separately, is she comfortable for that fellow who has brought her to be present at the time of examination? If she is not comfortable, we can deny also her presence. Many times relative or person who has brought that child to you insist to be present at the time of examination or at the time of treatment inside a room. So we can very well deny when patient is not comfortable. So these are some provisions as per examination with relative is concerned.
So next is, so will we be called in the POXOs? Many of the gynecologists feel very scared because they'll be called to the court for either for the documentation or they have to give for the opinion. Will
Yes.
they be called to the court, sir? If so,
Yes,
what
yes.
is their role, sir? How to proceed? How to have
Court
this?
has all the power or privilege, I would say, to call any doctor for evidence, because ultimate goal is to come to justice and to give justice to the person who has been victim of sexual offense under POXO Act. So to prove that very case, naturally documentations are required, opinion from expert persons are also required, and other witnesses are also taken into consideration. It is not merely on opinion from doctor who has examined that very patient or treated that very patient is enough. So court has all the power, but doctor is under obligation to be present in court whenever he is called for witness and to give opinion with documentation.
Yes, sir. So as it is, so when a minor girl comes to us with her mother or with her father or with her guardian, and we are to proceeding with a medical termination, so we have to do all these things, that we have to take a proper history, we have to take the consent, and then we have to register this case as a medical legal case, and we have to inform the police under POXO, and then proceed with an MTP, even if it is a legal gestation, even if it is within the legal gestation age. As you correctly said, within the 20 weeks we have to get one medical consent, and if there are more than 20 to 24 weeks, that we have to get two two persons consent, two persons opinion, and if it is more than 24 weeks, we have to send to the board to opinion to for the termination, and we should treat them and then get the MTP done. Is there anything else that we should do for this girl, sir, after the all the process that we do? Because when under a POXO, all these things comes under that. Is there anything apart from this that we have to do for them, sir?
This age group is vulnerable age group, I would say. When any person under 18 passes through this type of bad incidents, they are there could be nervous breakdown or psychological trauma also. So we can offer them psychiatric support or clinical psychology support in this type of situation. And CWC, that is Child Welfare Committee, are very good institution in this type of situation. They take utmost care, or many center, they call it a one-step contact center. So once a parents or any relative approaches them in this type of situation, they take care of this type of cases, and they will offer all the assistance then after in this type of situation.
So we have some interesting case scenarios, sir. One or two we'll discuss, because sometimes it comes as a routine that a 16-year-old girl elopes with a person, 19-year-old boy, with a very much concern, with very much willingness, and both of them are very much have a consensual sex and have a they elope and get married. So what is this implication, sir? What is the importance in their marriage? That is the teen marriage. They are getting married below 18. What is their implication, sir, regarding the POXO?
Even if it is with consent, consensual consent, because any minor's consent given is not valid consent in eye of law, because minor cannot give consent for this. So in this type of situation, even if it is with consensual sex, with consent, then also it becomes a case of POXO if she is minor. So we have to deal with accordingly. Just we discuss that we have to deal with this patient. We have to inform police. If at all reach for termination, we have to collect product of conception in normal saline, and it is to be handed over to the police. So we should be very clear. Whenever she is minor, even if she is married, even it is with consent, then also we have to inform police, because here age matters. Marital status or consent on part of minor, doesn't matter.
Yes, sir. Thank you. Thank you, sir, for that clarity, because many a time this is the problem that comes, because many a times they have a consensual sex. The boy is treated as an offender, even despite their consent. And sometimes the girl will say it's a romantic case, but even then it doesn't prevent them from putting an FIR against the boy. So it is mandatory for us to report to the police. And even if it has happened in the school authorities has to inform. That's very important. If they come across any under 18 eloping couples, they have to inform. That is very important, that we should really make them aware. The POXO implies even for the school authorities. It is not only we doctors, but also it is the school where it happens. So that also very importantly we have to understand regarding the POXO. And another important aspect, sir. What about the teen relationship consent, sir? Because many a times they come for a teen pregnancy, abortion, or abortion even with a mother, or even with a elderly men getting married to an elderly woman, a young girl. They come for a consent. What is the consent and its confidentiality, sir? What are the dilemmas in this teenage relationship, sir?
Just I mentioned prior also, as far as examination part is concerned, if she is more than 12 years, she can give consent. But for termination of pregnancy, she cannot give consent. And for that, consent of guardian is required. And this is provision under Act. And when there is provision under Act, you are not going to breach confidentiality of that very patient. So if you involve guardian for consent, and if you discuss that very case with guardian, you are not breaching confidentiality of that very patient, because she is minor, and under this Act, she cannot give consent for termination of pregnancy.
So that's it, sir. So POXO says that marriage does not provide immunity if a girl is below 18. So husbands can be booked under POXO even if it is a marriage with the proper families, understanding with the family, inside the families or within the families with a proper consensual marriage. Even that, it should be booked under POXO. And medical professional, we must report any pregnancies below 18, whatever the type of pregnancy, whatever it happens in whichever settings. And definitely the cultured norms do not override the act, because many a times in states like South India, like Tamil Nadu, Telangana, such marriages are very customary. They get married within the families, within the more maternal uncle marrying a girl who is very young. This is very common in our south part. So in that way also, cultural norms do not override the act. So enforcement of POXO definitely can clash a lot of legalities between the law and the community practice. But here is the main thing is the child's safety, which is prevailing in this act. So to summarize, as rightly pointed out by Sir, that the consensual teen marriage, even it should be treated as rape according to the POXO, and we should put a FIR, and there is always will be an arrest and trial, and social follow will happen even if it is a consensual marriage. That's very important. Then definitely even the cousin, uncle, niece marriage happening within the family with the full family support. But even if the marriage is below 18, then it is punishable offense under POXO. And marriage within the kids, it is always an ongoing case of POXO, because many times even it's an ongoing POXO case is still reported when they get married at a younger age, having a children, but still having a POXO cases which is still going on. So definitely there is a challenge for this POXO in our part of country, mainly because we have a patriarchal system which always normalizes in silence, and we always have a victim blaming and denial and fear of stigma, which is the main challenges that we are encountering with the teen marriage, teen pregnancy, which is happening very much common in our country. That is the reason that so many cases of POXOs are not being reported to the police. And we also have a lot of issues related to the family honor protection, which also leads this type of a marriage under 18, and lack of sex education and very much the caste biases and class biases, which is making this more vulnerable. So definitely we need a lot of improvement in this type of a patients, because in POCSO, very important is the one-stop crisis center, where they have a very good psychosocial support and rehabilitation being happening in few states, but in many parts of India, this rehabilitation is very much neglected. And that is the reason that many a time the POCSO cases, they'll land up in a long-term maternal mental health care problem, which is very much importantly not taken care and which have been neglected. And it is a very important reason that many a times the POCSO patients have a very much problem in the mental health in the long future. So definitely, as a practitioners, we should look into the healthcare. We must have a proper training in POCSO, and handling of such POCSO cases are very important, especially for the gynec and the pediatrician. We should have a proper education about the POCSO, and we should understand the law and the policies, and we should also understand how to rehabilitate this POCSO victims and how to properly present to the court, which is very important. That will create a future world, which is a very important one in related to the teen pregnancy. So to conclude, POCSO in India is a powerful law, but its success lies not just in its existence, but it is in its understanding, acceptance, and application across all layers of society, from the gynecological clinics to classrooms and also from homes to court. Sir, over to you to say a few words about the POCSO for all our gynecologists who are listening to it, sir.
So, as such, we have discussed almost all aspects related to POCSO and our OBGYN practice. But many times, our doctors' friends are not well versed with these provisions, and they treat this type of patient very casually. Today only there was phone call from one of our gynecologists from Karnataka. She had delivered a patient by cesarean section, and at that point of time, a patient was looking like major. So they didn't inform police. As such, he was minor, and now after some time, police had come. Why you didn't inform police? So this type of problems may occur. We should be very careful. We should be very vigilant. If at all we have little doubt that patient seems to be minor, because age determination is burden is our responsibility. Burden of proof is on our shoulder to prove. So we can ask for any ID proof as far as age part is concerned. We can ask for school leaving certificate, Aadhaar card, election card, or any other ID proof to confirm. And if at all we have doubt, then also we have to inform police, and we have to mention that it seems to be minor. Please get it confirmed by forensic medicine opinion from nearby medical college. So that is up to police station to deal with further. But once we inform, our job is over. We are not complainant. We are informer only. But we have to inform. And just I mentioned, if we fail to inform, there is a provision of 6 months of imprisonment, and that we cannot afford. And that is why we have to inform.
Thank you, sir. Thank you so much. Thank you. It's a real honor to have you, sir, for this dialogue. And you have clearly said everything about the POCSO, what every one of us should know, each and everything point by point you said, sir. Thank you so much, sir. So we are moving on to the next second session. I have the great pleasure and honor to welcome the chairpersons for this session, Dr. Pinky Kataria. Dr. Pinky is the secretary of the Nadidad OBGYN Society. We welcome you, madam. And I have the great pleasure to welcome Dr. Anand Bagde, who is the secretary of the Jamnagar OBGYN Society, and Dr. Hitesh Chauhan. Sir is the, he's actually, he's specialized, he's an experienced OBGYN, over 10 years of clinical practice, specialized in high-risk obstetrics and wide range of gynecological services, and as a proficient in diagnostics, and also he's a clinical expertise in OBGYN, and also has an interest in infertility treatment and management. We welcome you, sir. Over to you to chair this session to introduce the panel moderator and the panelists. Unmute, sir. Yeah.
Good evening to one and all, and thank you, Madam Dr. Jairani, Madam, for giving me opportunity to participate as chairperson in this wonderful session. I most welcome to Dr. Aruna, Madam Suman. She is the professor of obstetric department at Medical College, Jagital, Telangana. Pastly joint secretary of FOXI 2021. She is national coordinator to to women committee, practical obstetric committee of November 2024
Thank you so much,
She is
Doctor.
South Zonal Coordinator FOXI 22-23, Adolescent Health Committee FOXI member.
Thank you
She
so much,
was
Doctor.
Vice
Thank you.
President of OGFH 2020. She is
Thank you so much, Doctor.
Sir, kindly introduce third expert. Sir, Chauhan sir, can you introduce sir also and the other panelist? I think.
Okay.
I think Archana, you can carry on.
Okay.
Sir, please, sir, please introduce sir. Sir, you have to unmute. Yeah. So
yeah.
you have to.
Hello.
Yeah. We can hear you, sir.
Yes, madam. Slide was second speaker. No, this is a slide of Dr. MC Patel, madam.
Expert for the.
Sir is the expert for this panel, sir.
Yes. It's really a privilege to have Dr. MC Patel, sir, as an expert. We all know whenever there is a medical legal problems in our area, in Telangana, Andhra, wherever it is, we remember, sir. Sir, many doctors called me and I used to give your number. You were readily available, given them advice and guided them in a proper way. Thank you so much for being so available, sir. And definitely you are like our Apad Bandhava. Whenever we are in trouble, legally, definitely we think of you. Thank you so much, sir, for being the expert. And wherever you want, you can stop me, intervene and speak, sir. And let me introduce the other expert. Dr. Deepika Singhavi. She's Secretary of WAPI OBG Society. Next. Yes. Now, my esteemed panelists, Dr. Akash Gajar. His current experience, he's a director of Akash IVF Center, Ashirwad Hospital at Chikli. And working as fertility consultant, endoscopic surgeon, and embryologist is Akash IVF Center. I welcome you, Dr. Akash.
Thank you, madam. Thank you.
Dr. T. Ammani, she's a medical director at Janani Hospital, Chennai, and she presented many papers. OGSI 2008 A.L. Muralidhar Modalia Traveling Fellowship Award, OGSI, Dr. Esther Gold Medal for Best Research Paper, and her special interests are tubal microsurgery, cosmetic gynecology, reproductive medicine. I welcome you, Dr. Ammani. And the third panelist is Dr. Shantini. She's a consultant at KTS Nursing Home, Chennai, and she has got many academic accolades. Special interests are reproductive medicine, minimum access surgery, and high-risk obstetrics. I welcome you.
So much, madam.
And she's got gold medal in Dr. K.C. Nambiar Gold Medal, Maharaj of Travancore Prize, good, Maharaj of Cochin Prize, and she has got Dr. MGR Medical University medals and prizes in physiology, midwifery, and surgery. I welcome you, Dr. Shantini.
Thank you so much, madam. Thank you, madam.
Dr. Priya Kannappan, yes. She's there always, very active. and she will be answering well in the every panel also. She's the best outgoing student. She's a senior consultant, Dr. Mehta Hospital, GFC Fertility Center, Chennai. She underwent fellowship training in ultrasound reproductive medicine. And welcome you, Dr. Priya Kannappan. Dr. Vijay Lakshmi.
Thank you, ma'am. Thank you.
Kandasamy. Yes, she's a professor, Department of OPG at Chettinad Hospital and Research Institute, Care. And she's got 16 years of teaching experience. I welcome you, Dr. Vijay Lakshmi. Dr. Nirmala Murali and Dr. Jigna Ganatra. She is a president Rajkot of OB-GYN Society, and 17 years she's been working at Workout Hospital, Virani, NM Virani Hospital, and special interest in iris pregnancy. Dr. Jignesh Arvind Kumar Modi. He is Secretary of Porbandar Foxy and Fellowship in Gynec Endoscopy, VS Hospital, Ahmedabad. Have worked at many hospitals, presently working at Riddhi Hospital. He's been a faculty at various conferences like AICOG Ahmedabad, Yuva Foxy, SO GOG, and various CMAs. I welcome you, Dr. Jignesh. Dr. Hira Kodiathar, President of Porbandar Obstetric Gynecological Society. I welcome you, Dr. Hira. Dr. Devraj, Secretary, Junagand Obstetric Gynec Society. I welcome you, Dr. Devraj. So let me share my presentation. We'll discuss only the practical points so that we won't be wasting any time. No basics, please. And yes. Okay. So the topic is regarding the obstetric collapse, rapid response and timely intervention. We all know about the moderators and the panelists. Obstetric collapse is defined as an acute event at any stage of pregnancy up to 6 weeks of postpartum that affects the cardiorespiratory or central nervous system, resulting in a reduced or absent level of consciousness, potentially leading to cardiac arrest and death finally. So the incidence is 0.14 to 6 in 1,000 births. These are all the causes of obstetric collapse. Now, one of the panelists can take this. What are the different levels of care of obstetric patient? I mean, only the obstetric patient. How are we going to triage a sick parturient? Who is going to tell, please? You can take up.
Yeah, good evening, madam. Dr. Akash here.
Akash, tell me,
We
doctor.
have total 4 levels, starting from the level 0, 1, 2, and 3.
Okay.
0 means the patient we can take care in the normal ward. 2 means the patients whose condition is at risk of deteriorating. 3 level 2 means single organ failure or who require invasive monitoring. And 3 means multi-organ failure or require the advanced respiratory support with more than 1 organ failure. So level 2 and 3 should be managed. They are likely candidate for sudden collapse. So they should be managed in the obstetric ICU.
So anytime, any normal patient, any normal delivered woman, anyway, for the woman who is pregnant, we are not calling her a patient. We should call her a woman or a client, okay? Because it's a physiological process. But anytime she can suddenly deteriorate and become critically ill, and we'll have to identify the woman and treat. Timely intervention is necessary. What are the different levels of care in resuscitation in maternal collapse, and what are the key factors for consideration?
Every pregnant woman is a potential candidate.
So we have to be ready. Yes.
So we have to be ready regarding the irrespective of gravidas status, parity, or any past medical history. So recognition is very much important to identify any cause if there is. Communication and the teamwork. It's ultimately the teamwork which matters. We have to prepare for the healthcare facilities should have the protocols or the guidelines to take care of such patients. And the training of the staff, basic life support or advanced life support is very important. Document document. We have to properly document each and every event and each and every treatment which we are giving to the patient, and we have to counsel the relatives also simultaneously what is going on in the labor room or in the OT.
Thank you, Dr. Akash. And what are the levels of care while we are resuscitating the obstetric woman who has collapsed?
So similar to the other things, we have basic life support and the advanced life support, madam. So basic life support, it's about your ABCs of, your resuscitation. So we deal with the calling for help, and then you get the airway, breathing, circulation. And if at all there is a cardiac rhythm is not there, then you go with defibrillator. So these come under the basic level of support. And once your patient is more than that, then establishing the IV line. Like this can be done even by the general public, even a woman who falls on the road, anyone can do this basic life support. But once it comes to advanced life support, then it is always it is about the trained people, like whoever only the medical unit can give that. And this is about establishing your IV lines, giving medications, especially for preeclampsia, eclampsia patients or in PPH, and then connecting to the specific monitors, and giving the fluid, rushing them with fluid, and if at all going in for a perimortem section within 5 minutes. So all these things come under the advanced lesson.
So someone tell me, what is the specialized care that she needs after BLS and ALS? Besides that.
So this kind of the patient should be managed in the ICU. That is the first thing. So if we have obstetric ICU, then we can shift the patient to the ICU or some another tertiary care center, and investigations in the form of blood test, imaging to determine the cause. Specialized treatment, like if there is a hypovolemic or hemorrhagic shock, then we have to carry out the surgery or thrombolysis for the any kind of the embolism if we are suspecting. And we have to involve the other specialty also, like nephrologist, cardiologist, neurologist in the care of the patient.
So multidisciplinary team approach is important.
Yes.
And step up and step down protocol also we'll have to follow depending on her clinical condition, improving or not improving. So these are the few causes. Why do we fail to identify a sick parturient? What is the reason, and why the diagnosis is delayed most of the times?
First, we need to understand the normal physiology and the physiological changes that happen in the pregnant women. And we need to understand, we need to first diagnose the what is the pathology that has happened in the women who has collapsed. And
yes,
also
Dr. Shantini.
We need to have a better clinical exposure to diagnose the condition and the skill to treat women.
So we need to follow the checklists and standard operative procedures to identify, and we should have the basic knowledge, and knowledge of resuscitation also is important.
And
what changes in yes, Dr. Akash?
Yeah, these kind of events are relatively rare in our day-to-day practice. So we
yes,
have
it is a rare occurrence. Yes,
we have to keep in mind, or we have to suspect, we have to anticipate this kind of the event well in advance. Some patient is deteriorating or patient is going unconscious, then we have to anticipate in our mind that something is happening to the patient, and we have to be ready to treat or tackle that condition.
So you want us to have a high level of suspicion depending
yes.
on her history and care.
History, risk factor, or anything is there is.
Okay. So as Dr. Shantini said, some physiological changes during pregnancy can definitely obscure the clinical condition that is deteriorating. So we have to be very, very careful. And this is a maternal physiology that impacts on the resuscitation. The iotocoval compression, pregnant uterus comprises of external cardiac massage, blood volume is increased, and increased risk of stomach regurgitation and aspiration will be there. These are the few changes that will not let us do proper resuscitation. I'm not going to go into the detail. And coming to the question, obstetric collapse, cardiorespiratory and altered level of consciousness in any condition can be present. So what are the differential diagnoses? I mean to say, what are the different causes that we should remember? And stepwise approach for underlying cause for specific treatment when there is a maternal collapse.
Madam, when we see a patient who actually has, an obstetric collapse, the first important thing is they might be brought by their attenders. So the history as to what led to her collapse, and did she have any risk factors, what are the other medical disorders that she probably has. She might be a cardiac patient or a patient who has preeclampsia, which has worsened, and now she's suffered eclampsia. So that is very, very important. And if there is a previous history of any scar, and are we dealing with the uterine rupture? So all this, and whether there's a history of trauma.
Yes.
So this history taking is very, very important before we, as simultaneously as we receive the patient and resuscitate the patient, one member of the team should elicit a thorough history, and whether it is an event secondary to some drug intake, or whether it is a poisoning, consumption of some. So all that history is very, very important. We should definitely take a thorough history and go on with our management appropriately. So
most of the times, history will lead to the diagnosis at the first itself, more than examining the patient.
Yeah.
So proper history taking is always the primary important thing that we need to.
And it's a team
Basic
approach,
thing, no,
as you
madam, when
said.
it comes to collapse, we'll not have much time for history
Yes,
taking.
that is very
So
important.
it is a crucial few seconds. What you can gather, we just go with that. So I don't think we'll be able to get a proper history.
Yeah, with the
And,
resuscitation, simultaneously, you have
yes.
to take key factors of the history is
And
very, very
sometimes,
important.
in some cases, madam, there is undiagnosed underlying cardiac valvular disorder,
Exactly
like
correct.
hyperstenosis.
Yes.
So
That's very
that
good.
kind of the patients, they suddenly deteriorate because we don't know the actual pre-existing if there is any cardiac condition or not. And such type of the patient, even after the delivery or during the labor, they deteriorate suddenly and may unconscious, or they undergo
But
go
now
into
it is becoming
failure.
little less in Tamil Nadu because it's compulsory to do a maternal echo in patients, pregnant patients.
That's good, Priya. Actually,
Yes,
but
ma'am.
when we did the MDR review at Telangana, the more deaths are because of the
Cardiac.
missed cardiac events.
Missed cardiac, yes.
So,
Yes.
Even very
definitely.
recently, we had a patient who had a MS, and unfortunately, some of them do not come, despite the wide coverage from the health authorities.
Yes,
and,
Dr.
came
Vijayalakshmi,
with
well said.
AF.
Yes.
And we had one patient in recently, madam, like they didn't give us any history, patient collapse. Absolutely no reason was there. Everybody were clueless. And finally, it was domestic violence and the patient had a head injury with that. And she had a bleed and that is the reason she collapsed. So that was like, later diagnosed after a postmortem diagnosis. So like,
Yes, Priya, even we had similar cases like that, and Dr. Kiranmaya has done the study, and we were really surprised at the incidents. So definitely we have to take the history of intimate partner violence. That's also more important. And so we can monitor by this. We'll come to that later. And so how do we resuscitate the woman? Can someone take over this?
So as soon as if it is a lifeless patient, then immediately our first response will be to see whether the ABC. But if you see that she's not breathing, the most important thing is the CAB now. So you have to establish the circulation. So we call out, see whether she's responding. If she's not responding, check for her pulse, mainly the carotids. And if it is unresponsive, then you go on to start your chest compression. So even the also protocol is that if the patient is unresponsive, you start off with the chest compression till you get the team in. So it is to start off a code blue, depending on the obstetric code blue, depending on how the patient is. And if the patient's GCS is below 6, below 8 itself, she will need expert resuscitation. So we'll have to probably even intubate the patient. That is the earlier we intubate and establish cerebral circulation and prevent cerebral hypoxia, the better chance of reviving the patient and preventing long-term morbidity in her. Yeah,
yes, Dr. Vijayalakshmi, well said. Yes. And what about the displacement of the uterus? What is LUD?
Yes. Yeah, left uterine displacement. That is what is to be practiced. So when the person who's giving the compression, chest compression, is continuing to do at the rate of at least 100 to 120 compressions, the next person who's there should continually keep doing LUD. And they have to switch sides, because when you start sitting in that posture and giving compression, you will get tired out even at the end of a minute. So you have to switch places, and you take over the role of LUD, and the person who was giving the left uterine displacement should immediately take over from you and start giving the compression. And also, At the same time, if we are the code blue team comes in, then they start putting the ambu and keeping her, airway open and start giving the bag and mask as well. So it is 30:2. So 30 compressions followed by 2 ventilations, then 30 compressions. So we have a training program at our institute where all our obstetric OBGYN postgraduates undergo the
You are from which
advanced
institute, you said? Dr. Vijayalakshmi?
Chettinad Institute,
Chettinad,
Chettinad Hospital and Research
Oh,
Institute.
oh,
So we have the Advanced Obstetric Life Support Program, ALSO. So the PGs are definitely trained to go through that.
Very nice. So what is the correct procedure to perform the chest compressions in a collapsed mother? We need to have correct detailed procedure.
Yes. So it is always in this position, the hand placed like that, and the heel of the palm should be placed over her sternum.
Yes.
And the second hand should be kept on top of that, interlock like that. And
Okay.
our position or the pressure should come from the shoulder level. It should not be at the elbow. So that is very, very important, so that we give the right amount of compression over the sternum. It has to be, and we have to see that, it is continually done in the same position. And
so what is the depth?
We have to go at least 4 to 5 centimeters below to give effective cardiac compression. And that will allow for cerebral perfusion to happen. Passive cerebral perfusion will go on.
Okay, so there should be at least 100 to 120 per minute.
Yes.
Okay, 30:2 is the clue, and we have to remember that.
Yeah.
So
and this mask and neck tilt with the C position, keeping the jaw open and the palms like that, and the ambu bag completely, the mask completely covering her. The right fit mask is also very important. Place it over her chin and over her nose and completely. And the bagging should happen 2 breaths after the end of 30 compressions. So we, call out loud. That's very important. The person giving the compressions should be calling out loud. And once the 30 is over, the person giving the ventilation should immediately do the ventilation 1, 2, and then we continue. So it should be a team. And when the team responds, there should be a clear role for each and every member of the team. The person who's the team leader gives out or voices the commands, and the others follow the command and complete the loop of the circle of saying, yes, given, 2 breaths given. Then they start compression. And
very nice, Dr.
Time,
Vijayalakshmi. Yes, there should be one team leader, and she should be taking over all the handling all the situation. And she will call for help, and she will allot the proper work by asking them to do by calling their name, right?
Names.
Yes, very
Names
good.
should be called out.
And can I add, madam, like, when can I
Yes,
add?
Priya.
Usually
Yes,
when
Priya.
we start with that, for example, if it's an obstetric unit and if you have a multi-specialty, you have the other teams. So if it is an obstetrician who's a consultant or whoever's a senior will be the leader. And once I think your senior anesthetist or somebody comes where I think the leadership should be transferred. You just give the details, you just give a handover in the S bar, and then you just shift the leadership to them. And I think because once it goes across 3 or 4 minutes, I think, intubation and other things, it will be more of an anesthetic or an intensivist list unit rather than it is still under our care. So I think we should be ready to give over to the like the other leadership as well.
Very good that you have brought out SBAR.
Yes. And another important thing is at the end of the 4th minute, we have to empty the uterus as well. So that is also important. So as obstetricians, our role comes in there, even if we had SBAR and hand over to the team. And when they start, and if you find that it is, we are not able to, we have to empty the uterus at the end of the 4th or the 5th minute.
Okay. Okay, right. Then can you tell me about the indications of this AED, automated external defibrillator, and how to use it? What are the indications?
AED, madam, AED is mainly useful in a cases of shockable rhythms where there is a ventricular tachycardia or ventricular fibrillation. It doesn't work in asystole. So if we have to remember, if there is asystole, then we can't use AED.
Okay. And what is the safety, doctor? What safety are we going to follow when you're going to apply AED to the woman?
So that is also when the
all
AED
clear.
is placed. Yeah, the all clear. Shock going to be delivered, all clear. So the entire team is off away from the patient and the shock is delivered. So it's very important for the safety of the resuscitating
So you
team
have
as
to
well.
you have to call out 3 times all clear, all clear, all clear, and then only apply. Okay,
Apply.
right? And one thing we should not forget that we should not switch on the mobiles within some radius. I think I exactly forgot, but it should be kept away. Even our cell phone should be kept away from that.
And
Okay.
when the AED is analyzing, at that time we can continue giving the compressions.
Oh,
Only when the
yes,
AED, we just have to follow. The AED usually guides us through the whole thing. It is, it gives us voice commands as such.
Yes.
And once we have, it has established that it's a shockable rhythm, then, as you said, rightly said, madam, that the all clear, all clear, all clear. When their hands are off, then the shock is delivered.
Yes, yes.
Normally 200.
Very well said. Yes. Perimortem cesarean section. Evacuate the uterus. When, how, and what?
Even after 5 minutes of resuscitation, if we find that patient is not recovering, then we have to definitely go for and this cesarean section can be done. Incision can be kept vertically from vertical incision on abdomen should be can be kept, and a baby should be delivered as early as possible.
Okay. So
I
do we
beg
need
to
to take
differ
the
in that.
consent? Yes.
Actually, like people say about vertical incision, initially we used to consider that that is the earliest entry, but now we feel that all of us are so used to doing the fan and steel. So I think for us, vertical may not be that fast as a fan and steels. So now it is like, you
madam,
can use either of them.
Priya, madam, I beg to differ in that.
Yes,
because here you are not going to save anyone. Your idea is only to evacuate the uterus. Your incision with the scalpel will go straight through and through all layers of the abdomen into the uterus itself.
Even with the fan and steels, madam, even with the fan and steels will be able to go, because this is a patient whose heart is not beating for 4 or 5 minutes.
It depends on the individual skill.
Choice. Yes,
yes,
madam.
and the obstetrician's choice.
Comfort.
So actually they say for the quick delivery, we are not interested in the baby, we are interested in the mother. Definitely, whatever you want, the vertical incision can definitely be done. But if you prefer fan and steel also, that is not wrong at all.
Yes.
Okay, so we all know how to do the procedure, and I'm not going to go on that. Can impending maternal collapse be identified early, and how? There are few things that we can identify the sick parturient whenever she's getting deteriorated. Okay, when we are doing our round. So how can we identify those?
So usually nowadays we have the obstetrics early warning score chart, madam.
Yes, exactly.
So if you can plot it to that, actually, like most of the hospitals, the nurses are, taught how to escalate. And the moment 2 amber comes or 1 alert line comes, the nurses escalate immediately, madam.
Okay,
so,
right. And whenever there is PPH also, we can see the shock index, which is also important. Yes. And this is the formula for the shock index.
Yes, madam. Nowadays we talk more of shock index rather than the other about pulse and other things. So I think all of us should start following shock index.
Shock index. And now there is a modified shock index also. How can we improve the resuscitation outcome? What are the non-clinical strategies? Dr. Deepika Singhvi is there, who is a Sanghavi. She is the expert. Can she answer, please, if she's there? So these are the non-clinical protocols that we are supposed to follow.
Arna, sir, MC sir has some meeting, so he's left.
Sir,
MC
please answer. Sir, MC sir, please answer one question and you can go, sir.
Sir has just left. He has a meeting for
because post-resuscitation.
Okay. I thought there is one death. I thought sir will answer regarding that. It's okay if she's there. Yes, thank you, Jairani. And so, what is the post-resuscitation care that we are supposed? We have resuscitated the woman. She's doing fine. And what is the post-resuscitation care that we give her?
Ma'am, the mother should be in the resuscitation. She should be to a intensive care unit or a high dependency setting.
Okay.
And a multidisciplinary team should review her.
Okay.
still be taking care
Supporting
of her.
staff
The multidisciplinary team should take care
Yes,
of
for
her.
at least
physiotherapists
72
and
hours, she should be kept in HDU, and it should be a step up, step down protocol. If she is deteriorating, we send her to obstetric intensive care unit. If she is doing fine, we can send her to the ward after 72 hours. So this is the question for MC sir. Now there is a death, and how are we going to handle the situation? someone can take up this. And what is the clinical governance, debriefing, documentation, and bereavement care? Please,
So
someone can
first
answer.
thing, whenever a death has happened, madam, documentation comes a priority, because whatever best thing you have done, if you have not documented, it is equal to not doing anything. So it should be, whenever the instinct, you should have somebody assigned that time, if you have loads of staff there, to note down what are all the drug in which order is given. And it is always better for the senior to come and sit and document rather than handing over to a junior most PG or student there.
That's a good point. Yes.
So we have to sit document there, because poor documentation, because any patient can collapse, we can lose any patient, that is okay. In medical legally, only thing, if your document is poor, then we are charged with negligence. It is not that we cannot give a guarantee that every patient goes alive and every patient has a good outcome. There are some unavoidable circumstances also. But if the quality of care is given, and that will be the only thing to protect us there. So that is one. And debriefing should be done. Actually, after the situation, it has to be there, no blaming attitude, and it has to be done in a calm scenario. You cannot make the patient or attendant stand there and just give an opinion there. So you have to take them to a counseling area. We have a video counseling room, so where we sit and document, and we tell them. Sorry.
And madam,
And
one
also
thing
the
we
team
have to.
debriefing also should take place.
Yes.
Once we are
Yes, your team is
met with
already, yes.
a sad ending, and you are unable to revive the patient, and you have a maternal death on your hands, then as you rightly said, the documentation takes priority. When our minds are right at that point where we are fresh with all the details that we have done, stepwise, what we have written down, everything should be documented in the case sheet. And it's important that every member of the team is going to be carrying a mental trauma of not having revived that mother. We would have lost the baby, and we would have lost the mother as well. So right from the junior most postgraduate or the intern up to the senior most consultant will be having this trauma, that agony of having lost that mother.
And
that
always we
parturient.
should go back, do the auditing, complete,
Auditing is very important in
yes.
this
So
cases,
we
ma'am.
go how that learning. So this should be a part of the training. So what could have been done better in a non-blaming attitude and not finding fault? Like, see, you informed me late, you did this, this is why it's happened. So this should not be a thing after a poor outcome. So we have to just understand that there is a poor outcome, and then support each other, and to also give up, prevent further outcomes like this. So
An
we have to
internal
do that.
audit should definitely happen. An
Yes.
internal
Yes.
audit should
Audit
definitely
should be
happen
there.
before
Yes.
we go ahead to. We
And
will
other
definitely
side
be
of the
facing
story is there can be
district level audit.
mobbing, or the mob can be very aggressive, and you should know how to handle it. And how are you going to handle such situations?
If the hospital has a protocol, madam, we have this mob violence protocol. So we call the security, and they immediately inform the local police. So they come there. So the mob violence is limited. It's better with a good
involve
setup.
RMO and superintendent also, right? Or a dean,
Yes.
whoever is available.
The in charge.
Definitely,
Yes.
madam. Definitely.
And most important is, as we are resuscitating, we should pass on the message to our authorities, because we are dealing with an obstetric emergency here. They should be alerted even before any kind of so one member of the team should immediately inform the senior authorities, the medical superintendent, the RMO, as well as everyone should be informed. So they also are.
Madam, we have to call our colleagues also.
Yes.
Yes,
It is
Dr.
always a
Akash.
team effort, madam.
Yeah.
It is always a team effort, and one person has to be assigned to actually convey the happenings that is happening in the scenario to our authorities, so
And
that they
if
are also informed and they can give the
Even
inputs
the
also.
patient attenders should be informed.
Attenders
They
should
should be
also be
allowed
informed.
inside
Every step.
sometimes whenever we are resuscitating, so that they will see the scenario and understand.
And we have to
Yes,
take care
yes.
of our staff also.
But
It is not,
leaving at them and inside, I'm not sure, madam, whether they understand, because most of the attender, they come and say, they just press the chest and they kill the patient. The CPR is, that is how they
No,
come and say. The
you'll,
patient could have been there better
Yes,
rather
yes.
than somebody jumping on the patient and pressing her. So, like,
yeah,
I
but
mean,
yeah, that is there. But
Madam,
I
it's like
feel
either way,
if we
madam.
are in a
Even
place
if we
where
do
we are
not do anything,
resuscitating,
also
we
they
have
will
to
say.
allow them to, yeah, we have to allow them to see
Madam, the best
what
thing
are
is
all
to
the efforts
disclose
we are
the
taking.
bad
Yes, yes,
news
because
Exactly. They might
without
say that
police
we did
support.
not do anything at all to save the patient if we have
Yes.
if they do not see what
and
we are
madam,
undergoing inside that.
there is one responsible person who is communicating with the relatives timely.
Yes,
Exactly.
And
so in the
informing each and every day.
resuscitation team, there should be one person who is a communicator. He should
Communicate,
definitely
exactly.
communicate every
Yes.
step, whatever we are doing.
Still, the
Yes.
best thing is to disclose the bad news with the police support.
Yes.
Yes.
Okay. Yeah. Okay. Agreed. Yes.
Yes,
Who said
very
that?
true.
That's nice. Okay. Now coming to the
Yes,
case
madam.
scenarios.
I'm
Dr.
running
Ammani,
a private
Dr.
hospital.
Ammani.
private
Okay, Ammani,
hospital.
yes.
So
Yes.
I should be
And actually, see, as a few case
mentally
scenarios, I'm sorry about that. Case scenarios, vasovagal shock. It is very common because of the stress, because of the anxiety, because of the long standing position. And sometimes in the third stage of labor, it can happen. And what could it be? Can someone guess, please?
Inversion of the uterus.
Yes, inversion of the
uterine
uterus.
inversion.
How do we prevent that? Quick point wise. How do we prevent this kind of shock?
Yeah,
Even though it is
control
real, we
Prevention
should
is always
remember that.
controlled contraction.
Control cut.
Wait
control
for the
contract.
placental
Wait
separation
for the
and then
placenta
go
to
for
separate
control
and then go
contraction.
for.
Okay, right. So PPH, we all know how to prevent it,
Stepwise
predict it, and
protection,
manage
yes.
it. Yes, we all know. Let's not going to discuss that. And yes, this is the protocol, the steps of management. Suppose there's a primary, low risk, just delivered 30 minutes back, developed hypotension, breathlessness, acute hypoxia, coagulopathy. Before you realize,
Yes,
Amniotic
amniotic
fluid
fluid
suddenly you are
embolism.
really scared. So
Amniotic
what
fluid
could it be?
embolism.
What is the
Amniotic-
diagnosis and how are we
fluid.
going to manage? And many a times we had such kind of situation and we couldn't resuscitate the woman in a government hospital because of lack of facilities, because of many gaps, So this could
It's
be
very difficult to diagnose amniotic fluid embolism and very
Yes.
difficult to explain the relatives what has
Yes.
actually
Yes.
happened.
Another very important point, madam, I want to make here is if in the event of a maternal death, we should stand by and we should definitely say that we have to order for a postmortem.
Yes.
Because most of the time the relatives will say, no, we do not want a postmortem.
They don't agree. They don't agree for
they
that.
don't
But
agree.
still we have to offer
But we have
and
to
write
we
in
have
the
to,
case sheet.
yes. And even
Postmortem
when we've
is-
had recent inquiries, when we've had to face with the maternal death, the most important thing they say from the NHM audit is that you should not allow the attenders to take the body out without doing a postmortem.
And postmortem
We have
is
to
to
involve
save
the
us.
police in, yes.
Postmortem is to save us, not to identify the
Yes,
cause.
not- yes,
Whatever
yes,
the cause,
definitely.
let it be. But postmortem will save us.
But Akash, they won't agree for our postmortem whenever we offer. But
Yeah.
still, we have to
We have to
take their signature. But that they have refused postmortem.
Madam, we have to bring the police.
That-
We have to
that
bring the
should be
police
something.
into
That
the.
is a police
we have
matter.
to-
That is a police
yeah, we have
matter.
to bring it to the police into the.
And police is agree with us that relatives don't want postmortem, then it's okay. But nowadays,
have to inform the
new
police.
But the
scenario is
consent
going
should
on,
be
madam.
obtained before
Yeah.
releasing the
But madam,
releasing the
there is
patient.
our experience regarding the postmortem. A new scenario is going on. The person who is performing the postmortem examination, they talk to the relatives and ask the relatives that doctor has performed something wrong, and they call the doctors for some money. So this kind of
Oh
the
my
scene
God.
which actually we have faced in our practice.
Yes. Practically, we have faced all those, but we should definitely know how to handle such situations.
Yes,
It's very
yes.
important. So we should have a good team.
Yeah.
Jairani, you wanted to say something? Why did you raise your hand?
So I just want to agree with all of you because very important that when there is an obstetric collapse, we must do postmortem, which is very important. Even if the attenders refuse, even if they want to take the body, definitely you have to take the police into the custody, because that will save you.
Yes.
That is very important. I think if MC sir is there, he would have
Yes.
talked about it.
Reiterated,
Definitely, we are
yes.
not supposed. Don't take the consent in the case sheet, and later on, some advocate will come as a group and they will ask us, no, they don't know anything. You cheated them. You gave some wrong advices. That's how they will talk. So it is always important to inform the police. Let the police come.
Police
They
do the
have to
talking.
get everything. Their presence is very much needed and mandatory in an obstetric collapse.
You should
That's
not
a
release
good
the body
point.
without
Yeah.
getting the police into
Getting
the
the
picture,
consent
and
Absolutely.
we have to
police
stand
involved.
by our ground saying that we want a post-mortem, and when we document the cause of death as well.
So thromboembolism, so how are we going to suspect it and how are we going to manage it? Because sometimes embolism is very, very common with this. So how do we treat and how do we manage this? How do we identify this?
Most of the time it is an occurrence which probably, we see it in the post-partum period sometimes, and the patient may come with acute shortness of breath, and when you examine the patient, there will be unilateral limb edema, and there will be
Homan sign is
positive.
positive.
Yes, Homan sign will be
Yes,
positive.
there is a history of previous history of thromboembolism. If she's APLA positive, we have to take a proper history again, thorough clinical examination.
And I would always feel that prevention is better than cure.
Yes,
In
yes.
all women
Exactly.
with high risk factors, we initiate VTE prophylaxis.
Okay, so how do we prevent it, Dr. Vijay Lakshmi? Can you tell us how can we prevent this major maternal collapse with thromboembolism?
So I think we have to assess them, and the antepartum assessment itself should be done who are at high risk for VTE. And then we start the VTE prophylaxis as soon within 12 hours of the delivery, and continue. It is either unfractionated heparin or low molecular weight heparin. And we go by the guidelines, give it for the entire period of say 10 to 14 days. Sometimes we have a tendency to stop it after 3 days. So we have to definitely continue the entire duration of the prophylaxis, early ambulation, good, hydration postpartum. And if she's anemic, they're all very high risk women, high risk anemia and hypertension. So we have to put in the TED stockings, and that is very, very important. All these factors.
Risk stratification we have to do initially during her antepartum period. High risk, low risk, medium risk. If she belongs to high risk, definitely we have to continue almost up to 6 weeks sometimes, or else 10 days will be sufficient. If it is only prophylactic, only 5 days will be sufficient for her.
And at the time of planning for delivery and even after delivery, we have to again do the risk stratification. Sometimes, a low risk patient at the initial visit can be converted to a high risk during the delivery time. So we have to reassess and again stratification of the risk, madam.
Okay, right. Yes, definitely. And there is a sepsis. We have done a section for a PROM case. Now she's not having temperature is normal, but she presented with breathlessness, hypoxia, and hypotension. So what do you suspect? So without even rise of temperature, there can be sepsis,
septic
right?
shock can have a normal temperature without rising the temperature.
Yes. Okay. So there is something called as modified SOPA score. We have to follow. Again, we have to do the risk stratification. And there is a bundle care where we have to do the early intervention, input-output chart, measuring the lactate level. This is all very important for assessing the risk, and giving good antibiotic is also important. And now we have to follow the 1 hour bundles. Okay, before giving antibiotic, definitely we have to send for culture sensitivity. Yes, lactate measurement. This is also important, and we have to see the source of infection. Definitely, we have to remove it or drain it if it is necessary. And definitely take care of the woman.
And also the choice of our antibiotics also should be, the highest, the antibiotic that is appropriate for your polymicrobial cover. And as our ICU consultants will say,
negative coverage,
gram-negative coverage, hit early, hit hard. Only then you can revive the patient in a case of septic shock. We have to be very careful about that case.
Okay, so one time what happened, there was a case of...
as an institution, we should always have one SOP for antibiotic protocol, ma'am. We should actually discuss with the microbiologist for each and every condition. We should know which antibiotic to start with. But even before starting the antibiotic, we have to take the culture and then start the appropriate antibiotic in our institution, which has been standardized.
Yes, Dr. Shantini, we need to have the infection prevention protocols, and infection prevention team should be there, which is led by our superintendent or a dean of the hospital. Definitely, we should have the protocols, and SOP should be present, and we have to follow the SOP. Once it happened that when I was in duty, so there was a case of eclampsia, 37 weeks pre-eclampsia, she landed up with eclampsia. The intern as well as the postgraduate student have given magnesium sulfate at one time, the total dose. So what do I do? Because there is a cardiac arrest then. So what can I do?
It's because of the
Calcium gluconate.
Calcium gluconate.
Calcium gluconate,
gluconate.
and we have
Gluconate is to be
intubated
given.
the woman, resuscitated her, and we were able to save because of the calcium gluconate. Okay.
And
rule
most
of 10,
important
madam.
here,
10
madam, when
ml,
it comes
10%.
to administering these drugs, the team member should call out and say that I am giving magnesium sulfate. So this could have been prevented because of the slight lack of communication. The intern also loading, the PG also loading and giving it unaware. So if everyone opens out their mouth and gives a command proper and continues it and closes the loop of communication, we can avoid these kind of administrative drug errors.
Yes, correctly said, Dr. Vijay Lakshmi. I accept that this is a human error, and this can be definitely prevented by your closed loop questions and answers, right?
Yes.
Okay. Yeah, okay. Now we were giving her lidocaine, which is a overdose. No, how can we prevent this, or how can we treat the overdosage of lidocaine, the local anesthesia? So
I mean,
actually,
it is like usually it's not about the overdose, madam. It is usually an anaphylaxis which happens. Like, they become sensitized to the lidocaine. So just like any anaphylaxis, you go with your adrenaline, hydrocortisone. So those are the things which will help us to do that.
No, see, sometimes whenever we are giving the block and it goes into the blood circulation, definitely there can be an overdose. And now, according to the newer protocol, they say lipid emulsion, IV infusion can be given to reverse the cardiac and neurological effects.
Yes, madam. Yes.
infusion.
The only thing is not many institutes will have it, like not in an obstetric institutes.
Yes, okay. But we have
But
to
very
be
important
ready with
is
that.
to recognize anaphylaxis. As Dr. Priya was saying, many a times, despite giving the lidocaine test dose
also,
it does not, prevent her from going in for an anaphylaxis.
Anaphylaxis, madam, can occur with anything. It can occur with antibiotic also. So we have to give the test dose and then full dose.
Okay.
The most important is to administer the IM epinephrine. When we are meeting up with an anaphylaxis, the response should be immediate. It should be a quick response, and IM, the epinephrine should be given immediate IM. That is very important. Yeah.
What's the role of solmetrol? Solmetrol?
Solmetrol also can be given, madam, but as per what the ICU consultants say, you give intravenous solmetrol and IM epinephrine in this dosage of 1 in 10,000. There are EpiPens available. Epinephrine pens are also available.
But under the guidance of anesthetist, the anesthetist should be there when we give those drugs, because we are not really experts in giving those. Yes. So the teamwork and clinical governance is important. Documentation, as you all said, and incident reporting and debriefing to the women and family members is important. So every 6 months, once in 6 months, we need to have the skills and drills to actually revise the basic knowledge and enhance our skills, so that whenever there is a situation like this, we'll be able to do it better. And this is the algorithms. And definitely we have to think about the mental health of the women after resuscitation or before resuscitation or after delivery also. Yes, we should definitely talk about tocophobia, where the woman wants only cesarean section because someone told her the labor pains are really painful and intolerable. So definitely, yes, Priya. So mental health checkup, and so the chain of survival, early access, early CPR, early defibrillation whenever there is an indication, and early advanced life support is important. Early recognition and activation of emergency response system like code blue, performing CPR with a focus on chest compressions, defibrillation, advanced resuscitation, and post cardiac arrest care is very, very important. And we should have a enhanced skill and knowledge on this, definitely, to improve our or to save mothers. These are the references. Thank you so much. Thank you, Dr. Jairani. And thank you, dear panelists. Yes, it was a very good discussion. I have enjoyed it and I have learned so much. Thank you.
Thank you, ma'am.
Thank you, madam.
One more thing,
And,
madam.
thank
Foxy
you,
has
all my
started one
co-panelists.
initiative that is HRP A++, High Risk Pregnancy A++ initiative. So they accredit the center as well as the doctor also.
Yes,
so if the
yes.
center is recognized to manage such high risk patient, then it is much beneficial in terms of law also, that yes, our center is recognized, then we can take such kind of the emergencies of this kind of the patient.
Okay,
So
and you
Ideal
work
will
for
be
which
that all centers get recognition, isn't it? So,
Ideally,
yeah.
the center HRP plus AAA plus is a recognition by the Foxy. So it is proven in the court of law also that we have such kind of the registration. So we are able to manage such high risk patient.
So you had an assessment, Dr. Akash Gajar?
Yes.
Okay, okay. So
Is it part of the Manyata also, sir?
No, madam, this is like for the high risk center and the doctor, madam. I'm a part of that team. So like what they have is they have specifications, madam, including the forms requirement, the consent forms,
everything.
and like, the consent forms, the hospital should have like all these registers to be maintained, and all the facilities, like what all the things should be in labor room, what all should be there. They should have a HDU, they should have a ICU. So all these requirements are there, and it's just like a checklist, madam. We just tick the things and overall what are all there, and this we add on the marks and give it to that. And once they come to the basic qualification, that marks list is come there, then they accredit the center for high risk obstetrics.
So
like
Priya, this is for
Foxy.
only private hospitals or a public
No,
sector
madam,
hospitals?
government, medical college, everybody can apply, madam. Any center can apply, and it will be registered as high risk centers for the Foxy.
Oh, right.
So,
Jairani, I think we have finished on time with a good panelist.
Thank you, Aruna. You're always crisp and fast and very much into it. And it's
you have
lovely
given
to
me
have all
very good experts in the panel. Thank you so much.
Yeah.
Thank
so
you,
thank you
Aruna
so
Suman,
much,
madam.
all the panelists, and
Thank you, all my
thank you very much.
co-panelists as well.
Thank you.
Thank you, ma'am. Thank you, Jairani, madam, and thank you, Aruna, madam. Wonderful opportunity.
Thank you, all the panelists. We are moving on to the next session. We have with us chairpersons for this second session, Dr. Hiral Pandya. Madam is the secretary of the Baruch OBGYN Society. We welcome you, madam. And we have Dr.
Thank you, ma'am.
Deepa Rakesh Pitre, who is the president of the Vadora OBGYN Society. And it's a great pleasure to have all of you. And we have Dr. Piyush Kumar Vadalia. Sir is a practicing gynecologist at Vadali Hospital Maternity Home since 1999. And he's the present president of the Junag OBGYN Society. And he's the past secretary of the Junag OBGYN Society. We welcome you, sir. And I hand over to the chairperson. And we have Dr. Kanjan Maleshwari, who is the secretary of the Palanpur OBGYN Society. We welcome you, sir. Over to the chairpersons to welcome and introduce the speaker, Dr. Ruta.
Good evening, everyone, and I am very much thankful to Jairani ma'am and team to give me this opportunity. I welcome Dr. Ruta Vekaria, who did fellowship of 1 year in fetal medicine. She is having her own fetal medicine center, and she has worked as fetal medicine consultant at Ruta Hospital and IVF Center, and started a new venture known as Ruta Fetal Medicine Center in Surat since 2016. She was the ex-joint secretary of SOGS, librarian of SOGS, treasurer of SOGS, and assistant secretary of SOGS. So welcome you, Ruta Vekaria, for your next talk, ma'am.
Thank you very much. Am I audible?
Yes.
So should I share my screen now?
Please.
Okay. So can you all see the screen?
Yeah, Dr. Ruta.
Yes, ma'am. Yes, ma'am.
Yeah.
Okay. So should I start, ma'am?
Yes,
okay.
ma'am.
Okay, so first of all, I would thank you, Dr. Jayarani ma'am, for giving me this opportunity for this the talk, which is very near and dear to me as a fetal medicine specialist, and I welcome you all. So let's start without wasting much time. My topic today is fetal color Doppler in IUGR, how to interpret, when to deliver. I think my screen.
Yeah, your slides are not moving, Dr. Ruta.
Yeah, that is what I'm seeing.
You see in the corner, there will be the.
No, I need to just give a click. Initially I saw that, but why it is not moving? Is there an issue in that? Should I?
Now you go again to the.
Should I go into
escape?
Share?
You give it an escape and then come to the. Yeah, again, then share again. Yeah.
Share. Sharing screen has stopped as the shared window is closed. Okay. So okay. So first of all, how many vessels we image in Doppler? So generally, we image these vessels. First is umbilical artery, second is middle cerebral artery, third is uterine artery, fourth is aortic isthmus flow, and fifth is ductus venosus flow. Now, coming to Doppler and gestational age, the amount of perfusion in trophoblastic tissue is related to gestational age. For this reason, in interpreting the Doppler sonographic findings, gestational age must be taken into account. So what are the normal values of umbilical artery, middle cerebral artery, and uterine artery? In umbilical artery, in early second trimester, the normal values are generally 1.5 to 2, RI is less than 0.7, and SD ratio is less than 3. For middle cerebral artery, PI value in generally 28 to 32 weeks, it is more than 1.45, RI is 0.7 to 0.9, and in SD ratio is more than 3. In uterine artery, between 18 to 22 weeks, generally PI is less than 1.2 and RI is 0.3. Coming to umbilical artery Doppler technique, difference in Doppler indices at the fetal end, the free loop, and the placental end of the umbilical cord is seen. Impedance is always highest at the fetal end, and absent and reverse end-diastolic flow is likely to be seen first at this site. So as you can see these three images, the first image is of the placental end of the umbilical artery. The second image is of the free loop of the umbilical artery. And third image is of the fetal end of the umbilical artery. If we take Doppler at all these different sites, the indices will differ, definitely. And the best site to take umbilical artery recommended by all fetal medicine specialists globally is the free loop, the middle image. So as you can see the difference, if I take umbilical artery Doppler at placental end, the PI will come 0.8. The same patient, if I take umbilical artery Doppler at fetal end, the PI will be 1.1. So you can see this in the same patient, just changing the site will make the difference. So for the sake of simplicity and consistency, measurements should be made in the free loop cord. In multiple pregnancy, it is better to sample the umbilical artery just distal to the abdominal insertion of the umbilical cord. And in a two-vessel cord, at any gestational age, the diameter of the single umbilical artery is larger than when there are two arteries, and the impedance is thus lower. So as we know that in early weeks, umbilical artery Doppler changes till 12 weeks, there is absent end-diastolic flow. 12 to 14 weeks, end-diastolic flow develops. And when more than 14 weeks is there, diastolic flow increases. So there is a gradual decrease in the PI values. So now I'm showing these three gradual changes into the waveforms. So first image shows umbilical artery of at 11 to 12 weeks. It shows absent diastolic flow. First image. Second image is taken at 18 weeks. It shows relatively high resistance, but there is a consistent diastolic flow. And third image is taken at 28 weeks, shows low resistance waveforms. So these are the pattern which one should always, this is the pattern recognition for umbilical artery Doppler. And one should keep in mind that to identify abnormal umbilical waveforms. And last image is taken at 32 weeks. There is a low resistance and generous diastolic flow. So as the waveform changes, the PI value also changes. Now, what is the significance of umbilical artery Doppler? It only measures which provides diagnostic and prognostic information for the management of IUGR. Helps to identify fetuses at risk for hypoxia. High resistance flow, it indicates placental dysfunction. Absent diastolic flow indicates hypoxia. And reversal of flow indicates severe hypoxia. Better interpretation done by multi-vessel Doppler studies. And it helps plan timing of delivery and reduce perinatal mortality. Coming to some pitfalls of umbilical artery Dopplers, these are the pitfalls. If there is fetus compressing the cord and when the compression is released, so you can see there are two images. First image shows fetus compression. The second image shows compression is released. Now, these are the abnormal umbilical artery waveforms. The first image is of umbilical arteries in which we can see high pulsatility index. The second image also shows high pulsatility index. And third image, as you can see, there is absent end diastolic velocity and there is a pulsation in the umbilical vein as well. Very high pulsatility index, means high PI. And fourth is severe cases of reversal of end diastolic frequencies. Coming to next vessel, which is MCA Doppler, means middle cerebral artery Doppler. So what is the technique? Technique of middle cerebral artery Doppler is very important because your entire interpretation of Doppler waveforms changes if you do not follow proper technique. So you have to take axial section of brain. There has to be adequate magnification. Pulse wave Doppler gate should be at proximal third of middle cerebral artery. Angle of isolation should be as close to as possible to 0 degree. Sample gate is very important. It should be always 1 to 2 millimeter. Repeat ideally 3 times. Avoid too much of under pressure of the probe pressure. Now I have taken a small video clip to show how we take middle cerebral artery waveforms. So you can see in this image, there is adequate magnification. Then sample gate is also 1 to 2 millimeter. And I think it's, okay, it's not true. Okay. So why middle cerebral artery? The middle cerebral artery is the most studied cerebral artery because it is easy to sample. It is highly reproducible. It provides information on the cerebral blood flow in normal and IUGR fetuses and brain sparring effect. It can be sampled at any angle of 0 degree. Now, waveforms changes as gestational age increases. Generally, MCA Doppler shows low diastolic flow in less than 11 weeks to 13 weeks. It just starts, it shows end diastolic flow and there is high RI. When you see intermittent absent diastolic flow, it could be a normal variant or it could be due to probe pressure, undue transducer pressure. When you see increased diastolic flow, it is also normal in the late third trimester, generally beyond 34 weeks. And MCA PI around 1.5 to 2 is considered normal. Now let's see first normal MCA Doppler waveforms. At 20 weeks, this is the normal MCA Doppler waveforms image. And 32 weeks, this is the normal MCA Doppler image. Now let's see abnormality, which is related to hemodynamics. So the first is a normal waveform and the second image is showing mild vasodilation. So there is increased diastolic flow in the second image. And in third image, there is a marked vasodilation. There is increased diastolic, high level of increased diastolic flow is seen in the third image. Now coming to cerebroplacental ratio, cerebral resistance is always higher than the placental resistance in a normal fetus. Means PI of middle cerebral artery is always more than PI of umbilical artery at any period of gestation. Cerebral placental ratio is constant during pregnancies, especially after 30 weeks. In placental dysfunction, cerebral resistance is always lower and placental resistance is always high. Cutoff value is always 1. All values less than 1 are considered abnormal. Now coming to uterine artery, Doppler technique. We take sagittal view of the uterus and cervix. Uterine artery at the level of internal os before uterine artery branches into arcuate arteries. Sample gate is again 2 mm. Angle of isolation is less than 30 degrees. And we take generally mean PI of left and right uterine arteries. Coming to the technique of uterine artery, I think there is a lower, I think videos are not running. Can you see the videos? All?
Yeah, we can see, ma.
Okay. But I think it's not going ahead because, anyways. So this is the uterine artery, like this we take, and it's a sample gate. Now waveform, in early weeks up to 12 weeks, there is a low diastolic flow and diastolic notch is present. We all know. As gestation age increases beyond 12 weeks, there is increase in diastolic flow, decrease in PI, and diastolic notch disappears by 18 to 20 weeks. So I'm showing the changes of the normal uterine artery Doppler waveforms at 12 weeks, as you can see, shows high resistance with notch. And this is taken as at 24 weeks gestation. It's a mid-trimester uterine artery Doppler waveforms in which you can see increased diastolic flow. So at 12 weeks, as you can see in this first image, PI is high, 2.6. And at 24 weeks, as resistance decreases, PI also reduces. It comes to 0.5. Now coming to abnormal uterine artery waveforms. Normal impedance to flow the uterine arteries with the characteristic waveform of early diastolic notching. As you can see, there is an early diastolic notching. Increase impedance to the flow in the uterine arteries. Appearance of the characteristic waveform of early diastolic notching, which remains persistent. As you can see, there is a persistent diastolic notch. And third is very high resistance to flow in the uterine arteries with reverse diastolic flow. Coming to ductus venosus Doppler. So in ductus venosus flow, generally we see two peaks. One is at the S, which is ventricular systole, and D, which is called early diastole, followed by a nadir, which is called A vein. Now what ductus venosus Doppler reflect? It reflects the rapid chronologic changes in the pressure gradients between the umbilical vein and the right atrium. Okay, so now in this image, I'm showing the normal Doppler, normal ductus venosus Doppler, which is forward flow, that is towards the fetal heart. We generally measure pulsatility index, which decreases with advancing gestation. So now I'm showing different ductus venosus Doppler at different gestation. First image shows at 12 weeks. This is normal Doppler waveforms, which we take at 12 weeks of gestation. This is Doppler of ductus venosus taken at 21 weeks of gestation. And third is the waveform from the hepatic vein. So there is a slight, or if you see 3 images carefully, there is only a slight difference in the hepatic vein Doppler. So one should not misunderstand hepatic vein Doppler to the ductus venosus Doppler, because this Doppler is taken, hepatic vein Doppler is taken very near to ductus venosus Doppler. It's only a few millimeters away from the ductus venosus. So one should not misinterpret it and should not misunderstood the hepatic vein to the ductus venosus. Now, what is the role of ductus venosus in IUGR? Ductus venosus is the strongest single Doppler parameter to predict the short-term risk of fetal death in early onset of IUGR. Abnormal DV flow waveforms are seen only in advanced stages of fetal compromise, that is late stage of acidemia. Absent or reverse velocities are associated with perinatal mortality independently of the gestational age at delivery. Overall sensitivity is 40 to 70%, becomes abnormal 48 to 72 hours before the biophysical profile. Now, again, I am shown the different waveforms of the ductus venosus. As you can see, the first image is of normal ductus venosus. And as we go down, all these 1, 2, 3, 4, all these 4 are abnormal ductus venosus flow and images. Coming to next vessel, which is aortic isthmus flow. Very rarely taken. Only few fetal medicine specialists also take. So because the site to take is, you need expertise technique also to take aortic isthmus Doppler, because it is located between the origin of the left subclavian artery and the aortic end of ductus arteriosus. You require 2 sonographic planes to take that aortic isthmus flow. First is traditional longitudinal aortic arch view, which is called as a LA view in our very common language. And next is 3-vessel trachea, which is 3VT view. So as you can see, this image is of LA view, which is longitudinal aortic arch view. You can see in the down. And this is aortic isthmus, where we take the Doppler. And this is 3-vessel trachea view. And here where I have kept the sample gate, it is called aortic isthmus. And here we take aortic isthmus Doppler. So these 2 are aortic isthmus Doppler images. First is of normal aortic isthmus Doppler, in which you can see brief retrograde flow, very little retrograde flow. And this is abnormal aortic isthmus Doppler, in which the flow is reversed and the flow is retrograde in diastole. And this is image of FGR. Now coming to FGR, which is called as a fetal growth restriction. Now, all fetal medicine specialists nowadays, IUGR is no longer used. Now it is called as a fetal growth restriction. So what is true FGR? When expected fetal weight is less than 10 centile, Doppler signs suggesting hemodynamic redistribution as reflection of fetal adaptation to undernutrition, hypoxia, or histological and biochemical signs of placental disease and a higher risk of preeclampsia. And what is SGA, which is called as a small for gestational age fetus? In that too, fetal weight is less than 10 centile. It's a subgroup of small fetuses. It do not present with any Doppler changes. Before labeling any fetus SGA or true FGR, you should have accurate dating. You should have accurate measurement technique. And this SGA are always associated with adverse neurodevelopment. Coming to IUGR phenotypes, IUGR is broadly classified now worldwide, globally. Early onset IUGR, late onset IUGR. Early onset IUGR is first and second trimester. It is less than 32 weeks gestational age. Inappropriate trophoblastic invasion of spiral arteries means it is associated with placental dysfunction, mainly preeclampsia. Autoimmune, other causes of autoimmune disorders which affect placental vessels. Late onset IUGR is seen mainly in third trimester when gestational age is more than 32 weeks. Failure of fetus to reach the growth potential, and fetal hypoxia is always secondary to placental insufficiency. Coming to early onset IUGR, generally it represents 20 to 30% of all IUGR. Association with early preeclampsia, 50%. Severe placental insufficiency with chronic fetal hypoxia is seen in this. Umbilical artery Doppler is always abnormal in early onset IUGR. Immature fetus is seen generally, but there is a high tolerance to hypoxia, which is a natural history. It is associated with severe injury and or fetal death. Management is always challenging because it is early onset. Best balance between risk of leaving the fetus in utero versus the complications of the prematurity. Now coming to the stages of the sequential changes of the early onset IUGR. First changes when fetal weight is less than third centile. Second is when there is increased resistance, moderate stage, but no redistribution, in which you can see there is a cerebroplacental ratio is altered and uterine artery Doppler is altered. The third change is severely increased resistance stage. It can be associated with redistribution, in which you can see absent end diastolic flow, as well as when middle cerebral artery waveform is also entered, and it is also shows the abnormality. Fourth stage is severe hemodynamic alteration, in which ductus venosus alteration comes in the picture, and DV shows high PI values. It could be associated with reverse end diastolic flow, and you can see umbilical vein pulsation as well
And last is the final stage, in which always it is associated with final stage, fifth stage, when there is a high risk of fetal death, that is associated with ductus venosus reversal. Now, as I told you, fetal deterioration in early onset IUGR, when placental disease is seen, there is increased increment of placental impedance. Then when there is centralization sets, it goes into the moderate level, and there is a compensated hypoxia as well. And when there is a decompensated hypoxia, there is a cardiac ischemia and ductus venosus changes enters. Then there is a high risk of deterioration. Early onset IUGR, what are the key points of clinical management? When fetus is less than 28 weeks, there is a problem of mortality. First, determine gestational age. Second, the most useful determinant is ductus venosus Doppler, done in 26 to 28 weeks. Second is, if GA is more than 28 weeks, problem is going to be neurological morbidity. And third is natural history, use a protocol. And fourth, if preeclampsia, natural history is altered. So for many people believe fetal growth restriction or IUGR is equal to abnormal umbilical artery Doppler, but it is not anymore. Coming to next category, late onset IUGR. 70 to 80% of all IUGR is late onset IUGR. It is association with late preeclampsia, but association is very low. It is only 10%. Umbilical artery Doppler is normal in late onset IUGR or FGR. It is mainly associated with middle cerebral artery waveform abnormality, which shows PI value less than 5th centile because there is a chronic hypoxia. So there is an advanced cerebral vasodilation. And there is always association of abnormal cerebroplacental ratio values. There is a risk of acute fetal deterioration before labor, high association with intrapartum fetal distress and neonatal acidosis. Fetus is generally mature, so low tolerance to hypoxia and no natural history. So what are the clinical problems we face in the late onset IUGR? First problem we face is the diagnosis, correct diagnosis. Second is poor outcome, and third is long-term outcome. Generally, 5 to 7% newborns are affected. Detection is mostly less than 50%. More than 40% late pregnancy IUFD occurs, which is quite high. There are chances of neurological, cardiovascular, and metabolic sequelae. And one should differentiate between small gestational age versus late IUGR. So coming to key differences between early IUGR and late IUGR. In early IUGR, problem is management. Late IUGR, problem is diagnosis. Early IUGR mainly is associated with placental disease. In late IUGR, placental disease involvement is low. In early IUGR, hypoxia is severely associated, and there is systemic cerebrovascular adaptation. In late IUGR, hypoxia can be there, but there is a central adaptation. And in early IUGR, tolerance to hypoxia is there. It's a natural history. In late IUGR, there is low tolerance to IUGR because there is no natural history. Our early IUGR is always associated with high mortality and morbidity. In late IUGR, mortality is low, but there is a poor long-term outcome. Coming to management of the IUGR. So this is Barcelona staging of classification. Nowadays, we all use Barcelona staging of classification. Informally, it is called as a Gratac classification of staging. So in which there are 4 stages by which you should manage the IUGR or FGR. First stage, second stage, third stage, fourth stage. In first stage, when there is severe smallness or there is a mild placental insufficiency. So how you identify there is a mild placental deficiency? When expected fetal weight is less than 3rd centile, when cerebral placental ratio is less than 5th centile. There are percentile charts available in your machine also, as well as there are some software also which tells you the percentile charts. So you have to calculate according to that fetus gestational age, the percentile charts. And in this, when umbilical artery Doppler changes is there, when middle cerebral artery Doppler is also changes there, or uterine artery Doppler change is also there. 1, 2, 3, 4, 5. Any of the 5 things, any of the one thing among these 5 parameters is available, then it is you have to stage that FGR of first stage, and you have to monitor that weekly until 37 weeks. After 37 weeks, you can do labor induction. Second stage is associated with severe placental insufficiency, in which you see umbilical artery and diastolic flow absent. Okay, or either you see reversal of the aortic isthmus flow. In those fetuses, you have to monitor biweekly. You can pull the fetus up to 34 weeks. After 34 weeks, the Barcelona staging recommends cesarean section. Third is low suspicion fetal acidosis stage, in which there is reversal of umbilical artery Doppler, and there is role of ductus venosus flow. When you see high ductus venosus PI, then you should stage that fetus to FGR3. And in those fetuses, you should monitor 1 to 2 days. You can pull the fetus up to 30 weeks. After that, you should go for cesarean section. Fourth is the high suspicion fetal acidosis stage, in which you see DV reversal. At the most, monitoring is always should be done at 12 hourly. At the most, you can pull the fetus up to 26 weeks. Up to 26 weeks. After 26 weeks, you should go for cesarean section. This is again the same chart. I recommend everyone that you go to Barcelona staging system, you take out the print and you put in labor room, put in your USG machine wherever you are keeping the room also. The staging is very important. If you follow the staging by yourself, I think there won't be any much controversies between fetal medicine specialists and the obstetricians or whomsoever is doing the sonography, even radiologists. So this chart is very important. Only the pitfall of this chart is this chart doesn't apply into pre-eclampsia patients. In pre-eclampsia, this you have to monitor many things according to NST machines, according to patient's condition, according to BP, according to other parameters. You have to take your decisions of FGR. So I broadly recommend this Barcelona staging chart to everyone except pre-eclampsia. Thank you everyone for patient listening. Hello. Hello.
Yeah.
May I audible?
Thank you.
I
Thank you.
Thank you, Ruta ma'am.
Because it would be very tiring, and I think you all must be tired. So I just keep short and sweet.
It was very nice lecture. Thank you, Ruta ma'am, for such an informative and detailed study of all the artery Doppler, right from early pregnancy to late pregnancy with early IUGR and late IUGR. Thank you very much.
Thank you.
Thank you. Thank you, Ruta. Thank you, chairpersons. And thank you. It was nice to have you all. And,
thank you, ma'am.
Thank you. Thank you so much for giving all the depth and details, starting from the basic up to reaching to the importance of this Doppler in IUGR. Really, it is very much you're given all the depth of all these details. Thank you so much, Dr. Ruta, for joining us and giving your time in midst of your busy schedule with the personal commitments. You've been so sweet to join us. Thank you so much. On behalf of all the Tamil Nadu societies and Gujarat societies, I'm very thankful to the chief guest, Dr. Rohit Datta sir, for joining us in midst of his busy schedules in a short duration and blessing us with his inspirational talk. And thank you so much for the guest of honors, Dr. Parul sir, Dr. Deepika, Dr. Gitendra Sharma sir, who joined us late. Thank you so much. And a very special thanks to all the chairpersons, and very special thanks to my mentor, Dr. MC Patel sir, who is the mastermind for this beautiful webinar. Very much information packed with all his dynamic talk with me on the POXO. And a very special thanks to Dr. Aruna Suman for coordinating such a nice panel, very important panel about the obstetric collapse, which every obstetrician will dare or very scared to get a case. but she has made it so simple and very elaborate and very much up to the point to how to manage every obstetric collapse in a good way. Thank you, Aruna, for being with us, and a very special thanks to Dr. Ruta for being a very, giving a very depth and detail about all the Dopplers in the OBGYN practice, especially in the IUGR growth restricted pregnancies. A very special thanks to all the chairpersons, especially my special thanks to Dr. Chitul, Dr. Kokila Desai Madam, who is so busy that's why she couldn't join us. A very special thanks to Dr. Hiral Pandya, Dr. Dipti Pitri, Dr. Piyush for joining us, and a very special thanks to all the panelists here, especially Dr. Akash, who has been so much enthusiastic and very much into all our panel. It's a very nice of you, Akash. Thank you so much for joining us and sharing your time and giving all the inputs. And a very special thanks to my Tamil Nadu team, Dr. Amni, Dr. Shantini, Dr. Priya, and Dr. Vijay, and Dr. Nirmala. And a very special thanks to Dr. Jigna and Dr. Devraj, and also Dr. Jugana and Dr. Hira Kodeyata, Jignesh, for all their presence here for the panel. A very special thanks to all the chairpersons and all the senior faculties who joined us. And a special thanks to Sahiti for coordinating this platform. And a very special thanks to Sheel for giving us this platform. And a special thanks to Priya and Anita Shri for coordinating with all the speakers to get all the details for the flyers and making all the CDs. Thank you so much. And
Ma'am, just a small request.
One more invite. We have one more webinar on 70 with the Gujarat Societies. That also will be two things. Dr. Pankaj sir is there. He'll be talking on autoimmune disease management in pregnancy. And we have one more talk on the medical legal aspects in OBGYN practice. Sir will be doing the reverse panel. We'll be having sir's wonderful presentation on the concerns and about all the OBGYN practice. And we'll have one more talk on infertility issues with the women's violence with the women's life. So these are all the three topics that we are planning to have on 17th, the same time, 7 to 9. I would like to invite you all to be there to grace your presence. Dr. Ruta, you want to say something? Can you just share?
No, it's just a small request. I wanted a photograph of